Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Amrita Krishnan, who's the Endowed Chair for Myeloma, Executive Director of Hematology at the City of Hope. She holds multiple titles. She's the Judy and Bernard Briskin Myeloma Center Chair and Professor in the Department of Hematology and Transplantation at City of Hope, one of the premier myeloma centers in the country. And I'm privileged to have her today. She was a discussant on several of the abstracts at the recently concluded ASCO 2025 meeting. Welcome, Amrita.
Thank you, Ravi, and thank you for your kind words about our myeloma center.
Oh no, I'm not saying anything that is untrue. So you had an interesting title to your presentation at the ASCO meeting. You covered a somewhat wide variety of abstracts that were presented, right from bispecifics to trispecifics to novel methods of delivery of CD38s. So could you explain to us what you meant by buying a new iPhone?
Sure, thanks, Ravi. And I guess my timing is good because I realized they released another new iPhone. Um, and it's really exactly that. We've gotten a lot better with our drugs in myeloma, right? We've gone away from just high-dose melphalan. Every single time we get a new class of drugs, we're incredibly excited and realize we've made a leap forward, including image proteasome inhibitors. And, we really now are in this phase where we've moved so fast in terms of T cell directed therapies. And the question is now, advances beyond that, how do we decide what is truly an advance that we should adopt versus a variation on an older, I guess, model? And also, of course, toxicity is something you think about. I guess when you're buying your phone, you're thinking financial toxicity. Here, of course, we're thinking in terms of patient safety.
A very apt analogy there. So, as I said, you did touch on a variety of different drugs. So, we're going to take them one by one. So, first of all, guess you focused on some of the novel data that emerged on CD38 targeting in myeloma. What can you tell us here?
So I wanted to make the point that, the comparison that we really are thinking about is subcutaneous daratumumab to subcutaneous isatuximab, and also this idea of a different delivery advice. I did want to remind people that, initially when all you have is a flip phone, that's what you're going to use. And that was what IV daratumumab was. We were willing to put up with quite a bit of one, toxicity in terms of the rate of infusion reactions. Number two, inconvenience in terms of the length of time we used to have to infuse it when it was IV. But of course, in 2020, when daratumumab hyaluronidase was approved, that sort of completely changed the game. So in a way similar to when we got an iPhone, right? And we all threw away our flip phones. Um, and then, of course, to be balanced, talk about that IV cetuximab was approved in 2020. There are options for more rapid infusion of that as well, but still route of delivery remains, a challenge.
So, what is it at this meeting that was new?
This was really, of course, about subcutaneous isatuximab, but more so the focus, to my point, should be on this onboard delivery system, which is pretty innovative, right? It is a hands-free delivery of a flat dose of ESA, so important to know that flat dose, hidden retractable needle. This device is affixed to the abdomen, and then it, as a pretty unique way of the needle, sort of senses the interstitial tissue pressure and adjusts the rate of delivery. And this was a trial, of course, done for registration purposes to show non-inferiority compared to IV cetuximab.
So, it was the Heraclius trial, I guess. So, what did they show in the trial?
So in terms of efficacy, in terms overall response rates were equivalent. Safety, Not surprisingly, in terms of a sub-Q versus an IV route, we saw much less infusion reactions. Um, Now, while they didn't specifically measure this as endpoints, one can think of just in general in terms of safety. If you're using a hands-free hidden needle, needle stick injuries and repetitive strain are likely less for nurses who are giving these drugs. Um, the Now, of course, though, there was more skin toxicity because this is a subcutaneous delivery system compared to an IV delivery system. I also referenced one of the posters, the ASCO trial, which looked at patient preference of an IV versus sub-Q. And of course, with the on-body device, I should say. And again, a huge preference for this on-body device from patients and the healthcare providers. Lastly, was of course looking to the future. And for most people, the attractiveness of this is really the idea, could you at some point use this as a home delivery system? um, Given sort of the convenience of it. In terms of in clinic, of course, the median infusion time on the trial was 13 minutes, so that's certainly attractive. It is a fixed dose. So, I did raise the questions that one thinks about even in drugs, not just your iPhone, in terms of financial costs, right? Fixed dosing versus weight-based dosing. Also, how would clinic throughput change in a way that one could take advantage of such an administration method?
So then shifting gears, obviously, one of the hot things is immunotherapy and multiple myeloma. And I guess the next two abstracts were kind of focused on some of the advances in this field. So could you just lay the background for your discussion on this aspect of things?
This was really focused on the fact that we have so many um, immunotherapy options, and we have the bispecifics approved in fairly advanced disease. We now actually have three BCMA bispecifics approved in four or more prior lines of therapy. But of course, naturally, as we do in myeloma, everything that we get approved in late line therapy, we want to look at in early line therapy.
So what was it that was presented at the ASCO meeting in this regard?
So they presented the Magnetism 6 trial, and this trial actually had a newly diagnosed cohort and a relapse cohort. The data she presented was on the newly diagnosed cohort.
And what was the bottom line of this presentation?
Well, again, it becomes the question, do you need another drug in this space? And especially since, many of us are very comfortable using daratumumab, lenalidomide, dexamethasone. So the idea of adding elranatamab, daratumumab, lenalidomide, do we need to? And I made the point here that there are a group of patients who still do not do as well with sort of what our standard DRD regimen is, and that's really the high-risk cytogenetic subgroup.
And so I understand that obviously there is this still conflict between whether three drugs versus four drugs for this population should be considered. And so I think you touched upon the Cepheus study, which was the four-drug regimen.
Exactly. And here I just wanted to make the point that yes, we have adopted four drugs even in older patients, but they're very selected older patients. So none of the patients in this trial were over the age of 80. And, again, they were frailty scores of 0 or 1. So again, a pretty highly selected older population.
So in this presentation on the magnetism 6 study, what was it that they ended up with in terms of patient demographics?
So here you can see that what the median age was 75, and they did include patients uh, um, over the age of 80. And we also see that about a quarter of the patients were deemed frail by a modified frailty score. It's a little hard to compare across trials in terms of frailty scoring, but at least by their definitions, they did include frail patients here.
And it seems you try to put in perspective with the three drug regimen of Dara, Revlimid, and Decadron.
Um, because I think that was probably more a fair comparison for what we would do for an older, frailer population. And again, we're all so comfortable with that regimen. Um, and what one could see was that the safety profile was actually pretty good using this new regimen. Certainly, they saw infections, grade 3, grade 4, 19%. But I wanted to remind people that that's also what we saw with DRD. And again, neutropenia slightly more, but really not significantly more with the ELRA-DR combo versus the DRD combo. Efficacy, while the response rate seems extremely high, up to 97%, we still don't know durability of that response. So that's where the questions become. And we also don't know data in terms of the high-risk cytogenetic group. So that we also want to see how that plays out.
So, and there is some data from some of these trials on the shape of the curve, how it may emerge.
So at least this approach seems promising of using BCMA targeting upfront plus daratumumab and len. This was the Majestic 7 trial that was presented about a year ago, and you can see that's an incredible PFS curve. Having said that, though, it's of course extremely short follow-up, and one wants to see if this will hold.
And so I guess you summed up some of the ongoing studies with the various bispecifics.
And so here, I wanted to just make the point that we struggle with tumor heterogeneity in myeloma, but trying to target sequentially is we seem to lose efficacy in terms of progression-free survival, meaning that if you go to a start with a BCMA target and then you move on to a GPRC target, you can see your PFS drops quite a bit. And of course, that's not just target mediated, it also has to do with the T cell environment. But instead of trying to do it sequentially, if you do it at the same time, dual targeting, there does seem to be promise of better results. And this was the redirect trial where they did use teclistamab and talquetamab, and we got a much higher overall response rate. Now, of course, it came at the price of other toxicities, a higher rate of neutropenia, for example, and you still get the GPRC tox in addition to infection risks that we see with BCMA bispecifics.
So obviously, these last two slides, you were laying the background for one of the other presentations, which is, instead of sequential or dual targeting using two different drugs, how about targeting them all at once?
So this was a really exciting drug. We are part of the trial. Um, exactly doing dual targeting BCMA, GPRC, and CD3, so tri-specific. The schedule of the drug is Q4 weeks, and that may in part explain why, while you do see some of the GPRC toxicities, such as the dysgeusia, tends to be less severe, and the weight change, there's a slight drop initially that seems to recover um, from that.
So, and what about other side effects potentially?
So, the infection rates also seem lower than what we saw initially with the BCMA bispecifics. Now, whether that's because, again, the dosing schedule, perhaps in part, because if you remember, for example, teclistamab, we give it weekly. Sometimes we then switch to Q2, again, versus a Q4 week cycle. But also, of course, we've gotten a lot better at understanding supportive care and giving IVIG, for example.
And so, what are the overall results and the positives of this study?
So the positives of the response rate was incredibly high, approaching that of what we see with CAR T cells. Um, we don't know data though in these groups that we want to, EMD, for example, patients with high-risk cytogenetics. And also the follow-up on this trial was still relatively short at 12 months. Um, and then lastly, we don't know what happens if you relapse after this drug. Are you got now going to be mutations in both targets, or the fact that you're dual targeting hopefully decreases that selective pressure?
So, what in all was your conclusion of the discussion that you provided on these three somewhat disparate abstracts?
That we are making progress in myeloma. We have drugs that do seem to show improved efficacy, such as the trispecifics, maybe the BCMA DARA Rev combination as well. Toxicity seems to be manageable now as we've gotten better with supportive care and all of these agents. Cost remains an issue, and we need to look at ways that we can um, be thoughtful about costs, such as maybe fixed duration of the trispecifics, fixed duration of the Elra-Dara-Len combo. And again, as we mentioned, differences in the way we deliver drugs in our clinic with using the on-body device.
So, does any of these represent a new generation of maybe AI-enabled iPhones?
I would say the tri-specific for sure. I mean, it's just exciting to have a drug that's such high response rates off the shelf. Um, and again, once if we see durability of those responses, I think it will really be landscape changing.
So I think that obviously progress continues to be made, and there is more than one tri-specific. Obviously, you discussed the one that was in the oral session. I'm told that there was another one that was presented at the meeting in a poster discussion session, and then subsequently at other meetings as well. How excited are you about the tri-specific, which I think is in that case CD38 BCMA directed?
Exactly. I think also equally excited, there's space for both, because I do think that CD38 targeting remains a viable strategy. Um, and so doing it in a way that sort of augments the T cell part of a drug is important. And of course, then you don't have the GPRC related toxicity. So I think, again, that is an exciting drug. Same questions there in terms of durability of those responses, EMD, very small number of patients. So all those questions we want to sort of see answered as those trials mature.
No, certainly. And obviously, there are also CAR T cells that are being looked at that have more than one target. So these are certainly exciting times. So I really appreciate your spending the time to educate the audience about some of these key developments from the ASCO meeting. And I hope I can reach out to you again for new presentations as they are made at the congresses.
Thank you, Ravi. It's always a pleasure to talk to you.
Likewise. Thank you.